Good afternoon, everyone, and welcome to the national webinar, Leveraging Medicaid Quality Metrics to Improve Care for Children with Chronic and Complex Healthcare Needs. My name is Karen Van Landehem. I'm a Senior Program Director with the National Academy for State Health Policy, and it's my pleasure to be co-sponsoring this national webinar with the Lucille Packard Foundation for Children's Health, the funder of this work. Before we begin and talk about the purpose of today's webinar, just a few logistics. Your audio should be coming through your computer speakers, but if you're experiencing any audio difficulties, you can dial in via your phone using the phone number and passcode that's on the slide right now. We are going to have 15 minutes at the end of this webinar for Q&A, so I encourage you to jot down your questions as we go along, and please feel free to type those questions into the chat box. We'll try to do our best to get to as many questions today as we can. And then finally, just to give you a heads up, we're going to have 3 poll questions throughout the national webinar. We just encourage you to use that poll. We want to get a sense of who's with us today, what your familiarity is with Medicaid quality metrics for kids with special health care needs, and then what are some of your biggest challenges. So please look for those poll questions throughout the webinar. Just a little bit about the National Academy for State Health Policy if you're not familiar with us. We're an independent academy of state health policymakers that work together to identify emerging issues, develop policy solutions, and improve state health policy and practice. We cover a range of health policy issues at the national level for state health officials and others that work with state health officials. We have a large body of work in children and family health, and then we also have specific work on children and youth with special health care needs. So we're just very delighted to be part of this work and to be talking about Medicaid quality metrics for children and youth with special health care needs today. In terms of our webinar today, what we plan to accomplish is that we would like to have a little bit of an overview on opportunities and challenges in Medicaid quality measurement. We will first hear from Rita Mangione-Smith, who's a professor-in-chief with Division of General Pediatrics and Hospital Medicine at the University of Washington. And then following Rita, we'll hear from our colleagues in the state of New York who will talk about state strategies and approaches to quality measurement that they're working on. Just by way of a little bit of background, as many of you may know, many state Medicaid programs are focused on strengthening and transforming how care for children with chronic and complex health care needs is delivered and paid for, including things like transitioning more populations of children with special health care needs into Medicaid managed care, integrating physical and behavioral health, improving the delivery of services through long-term services and supports, and implementing programs like Health Homes for Kids, which you'll hear more about that from the New York team. Quality measurement is critical to these reform efforts and to ensuring that children with chronic and complex needs are receiving quality care that addresses their unique needs. We know that Medicaid quality measurement is a priority for many states and that many are focused on that work right now. However, what we've seen and heard from state Medicaid agencies and others is that Medicaid quality measurement improvement for children lags a little bit behind that for adults, and that this lag is even more pronounced for children with chronic and complex health care needs, and there's many reasons why. In the spring of 2017, NASHB, with the support from the Lucille Packard Foundation for Children's Health, we convened a national work group of state Medicaid agencies, state Title V children and youth with special health care needs programs, families of children and youth with special health care needs, child health services researchers, pediatric providers, and federal agencies to discuss and assess the state of Medicaid quality and measurement and improvement for this population of children. And then based on this work, we have developed an issue brief that examines the challenges and opportunities in this area and identifies 10 key strategies that states can use to advance quality improvement initiatives for this population. We're excited that we're going to be releasing the issue brief tomorrow, Tuesday, November 28th. And on today's webinar, you're going to hear from one of our work group members, that's Rita Mangione-Smith, and then also from New York, and New York is featured in the issue brief. So with that background and a little bit about the logistics, I'm now going to turn this over to Ed Shore, who's a Senior Vice President with the Lucille Packard Foundation for Children's Health, and again, our funder for this work. Ed?
Thank you, Karen. And thank all of you for joining this webinar this morning. The Lucille Packard Foundation for Children's Health is a private foundation whose work is focused on improving systems of care for children with special health care needs. This population of children with chronic and complex health problems that we're discussing today are those that are needing the greatest services and most dependent on having high quality services. Our take on this has been that if we can get the system right for those children, it will work well for other children also. So I want to thank NASHB for doing this work and for organizing the webinar today. I want to keep my notes, my comments brief, because I'd like to hear what Dr. Mangione and Smith and the New York people have to say. But I do want to thank all of you in this first day at work after Thanksgiving for all the work you do on Medicaid and related programs to try to improve the systems of care for children in this country. We all know that that system is being threatened, and I think it's really important not only that it survive, but the quality of services that are provided through it remain very high. With that, let me turn that back to Karen.
Great. Thank you so much, Ed. So now for those who are participating, we've come to our first poll question, and you should see this on your screen. And we just want to get a sense of your organizational affiliation. Are you with a state Medicaid or CHIP agency, with a public health agency, health plan, researcher, or others? So we'll take a few minutes and let folks complete that poll. And while we're doing that, if you want to chat into the chat box, you can. If you're checking the other box, feel free to include in the chat box where you're from. We'd love to know that. All right, Anisha, let's close the poll, please. All right, so as you can see today, kind of a mix. We have several folks from the state Medicaid or CHIP agency, a large group from public health, providers, and then that other group. So looks like folks are chatting in where they're from if you've checked others. So thanks so much. And we have families as well. So good to see kind of a broad group of folks on today's webinar. So our second poll question is just we want to get a sense from you all as to what's your familiarity with Medicaid quality measurement for children with chronic and complex healthcare conditions is. Are you not at all familiar with this topic? Are you somewhat familiar, or are you well-versed? And we'll take a few minutes. All right, if we could close the poll, please. So it looks like we have about half of participants who have some familiarity with the topic, some who are well-versed, but a good group also that are not at all familiar. And so that's actually really great to know, and a good segue to my introduction again of Dr. Rita Mangione-Smith, who, as I mentioned earlier, is with a professor-in-chief with the Division of General Pediatrics and Hospital Medicine at the University of Washington, Department of Pediatrics. And as I mentioned earlier, we had the pleasure of having Dr. Mangione-Smith on the national work group that helped advise the work and the issue brief that we're going to release tomorrow. So with that, I'd like to turn it over to Dr. Mangione-Smith.
Thanks so much, Karen, and thank you all for attending today. So I'd like to start out by just giving you a brief outline of what I'd like to cover over the next 15 minutes or so. So first, I'm going to talk about why quality measurement is important for children with chronic and complex conditions. And then I'm going to go over some key questions that I really feel it's important to answer before you select quality measures to implement, if that's something you're contemplating doing. Then I'll move on to, those of us who are familiar with quality measurement think about 3 different types of measures: structure, process, and outcome measures. There's a strong desire by many to measure outcomes, and I'm going to review why we don't just measure outcomes, why we do spend time measuring structures and processes of care, and what some of the challenges are in terms of measuring outcomes for children. Then I'm going to kind of move on to opportunities for improving quality measurement now in the current state, and then aspirationally where I'd like to see us head in the future in order to do some better quality measurement. So what do we know from research that's been done on children and youth with special health care needs and children with medical complexity? Well, we know a few things from intervention trials that have been done in this population, and that's that those children with medical homes and access to care coordination services have better outcomes than those who don't. We also know that care coordination requires a substantial investment of resources, so it's important to prioritize and incentivize care coordination in the context of those limited resources. So really thinking about which of those children in the larger group of children and youth with special health care needs would benefit the most. We actually know very little about the quality of care coordination services being provided to this population of children, and we'll get a little bit more into why that is. Making the case that it's important to do this measurement, but it is challenging. So what are the key services that we need to provide to this group to improve their outcomes? Well, the intervention trials that I referred to previously did what are called bundled interventions. So they took several different things and put them all into an intervention together and applied that in a randomized controlled trial to children with children and youth with special health care needs. So some children were in our control population and received their regular care, and some received this bundled intervention. And what was included in those bundles? Having a medical home, having a care coordinator, having an individualized shared care plan that set goals for that particular child, and there was regular check-ins to see how the goals were being met or whether they were being met. Having regular contact with that care coordinator and having that person function as a single point of access not only to the complex medical system, but also to community services that a child with special health care needs might need. The coordinator did things such as obtaining subspecialty appointments for the child and their family, obtaining community services that they were having difficulties getting on their own, or helping with school issues that might come up. But the issues with the trials that have been done with these bundled interventions is we're not sure which of these things is really driving the better outcomes, because the studies did find better outcomes for the children who had this bundle of services. So we believe that all of those care structures, things like having a care coordinator and processes helping a family get community services that they're having difficulty getting on their own, are important. But we don't know, again, which individual ones are the most important. So if we don't measure whether families have these particular services in place from that list I just showed you, then we can't really understand what structures and processes lead to better health outcomes. If they're all mixed together, it's hard to know which of those things is really driving the better outcomes. And that makes it difficult to understand which structures and processes are the most cost effective. So where are we going to get the most value for putting something in place? Is it really the shared care plan that's the most important? Is it really investing in having a care coordinator for the children with the most complex disease? Where do we get the most benefit for our dollars? And that helps us to answer the question, how can we best increase value of care for this population? So as you think about this and you think about potentially trying to implement quality measures for this population, there's some key questions that I really feel you need to answer before starting. The first is, what is the purpose of your quality measurement? Are you doing it for accountability purposes? So in other words, is your organization being asked to publicly report on a particular quality measure as part of a pay-for-performance program, or a program that actually penalizes for poor performance? There are state agencies, obviously, that have to do this kind of reporting. So is it for accountability, or is the reason you're measuring really more focused on trying to do quality improvement work? So we want to know how we're doing and where we're not doing so well so that we can improve on that. Or are you trying to do it for both reasons? And in that case, harmonizing those activities is really important when you have limited resources. We can't measure everything, so ideally we would be using the same measures for accountability that we're using for quality improvement. And then you need to ask, at what level of aggregation do you want to measure? And what do I mean by that? So do we want to measure at the state level, at the accountable care organization level, the Medicaid health plan level, hospital provider, et cetera? That's really important, and we'll get into that a little bit more in the next slide. And also very important, the actions to improve quality. What are they? So if you're going to measure quality, we really need to understand who's accountable for improving quality based on reporting the measure results at your selected level of aggregation. So is it the health plan that's responsible for changing their services that are available? Is that what's going to improve quality? Is it a state policy that needs to change to improve quality? Is it something down at the provider level where care is actually on the ground being provided that needs to change? So think about who's accountable for improving quality based on the measure you're thinking about implementing. All of those, the answers to those questions are going to drive your subsequent decisions about which quality measure you might use. So one of those things is the data source for measurement. This is a really important issue, and it's related to the feasibility of doing quality measurement. So what data sources are available to you to support reporting at your selected level of aggregation? Do you have administrative claims data that you can access? Do you have electronic health record data that you can access? Do you maybe have survey data that you can access? Those are all important questions to ask, because different measures require different data sources. Then you need to determine, is it feasible for you to get the sample size you need to do the measure at your selected level of aggregation? This becomes a big issue in pediatrics because many of these children, if you look down at the practice level, you're going to have very few of them for one provider. So if you wanted to do provider level quality measurement. If you roll it up to the practice level, you might have enough children with a particular condition or problem to do valid and reliable measurement, but you may actually have to go all the way up to the health plan level to get enough children with a given condition or a given set of issues to do reliable and valid measurement. Super important. Why does the measurement have to be reliable and valid at your level of aggregation? Because if it's not, you can have unintended consequences, right? So if you're using a measure that is not valid at the level of measurement you're using, say at the health plan level, you might reward or penalize performance that you shouldn't be rewarding or penalizing because the data you have is not really telling you truth, okay? And acting on data from a quality improvement standpoint that is not reliably measured at the level where you're using it is also a problem. Doing quality improvement work is resource intensive, and you want to make sure that you can believe the results of your quality measurement before you start acting on those measures. So let's talk for a minute about structure measures, process measures, and outcome measures, and why don't we just measure outcomes. So this is how those of us doing quality of care research think about measurement. We think about the structures of care that are in place. So example, do I have a high-functioning electronic health record in my practice? That then influences the processes of care that I can give to a patient. So do I get routine alerts about screenings I should be doing with a child because of their condition profile? And then how does doing those processes of care affect outcomes for that child, their ability to attend school, their functional status, all of those types of things that we're really, what we really care most about are the outcomes, right? How well are children doing? So you would think if the outcomes are really what we care about, why aren't we just measuring those? Why aren't we measuring, school attendance and functional status and quality of life? Well, I'm going to talk about the 3 Ds that I always consider when I think about the challenges to measuring outcomes in pediatrics. And those are their developmental trajectory, their dependence on adults, and their differential morbidity when comparing them to adults. So let's look at each of these a little bit more closely. So what about their normal developmental trajectory? What's tough about kids is they're constantly changing through time, right? So if I look at a 1-year-old and I say they can't walk, that's not a problem. That's a normal outcome. That's within the range of what's expected. If I look at a 2-year-old and I ask that same question, can they walk, and they can't, that's a very poor outcome. So outcomes for children change as they go through different ages and developmental stages. So unlike in adults where we can just use the SF-12 measure to get at functional status and it applies to everybody regardless of their age, there is no single measure that you can apply to all children that will get at those functional status type outcomes. Even when we have instruments that are available for different ages and stages, the standards may be different for children with developmental delays or disabilities. And many of the children in the population we're talking about have delays and disabilities. So would those same measures really work in this population that we're interested in? The other thing is outcomes are delayed in children. So I'll give you an example. So you have a very rough delivery of a child in the neonatal period, but you don't start to see problems with learning disability until they reach school age. And that may be the result from hypoxia or low oxygen levels during the birthing process. So their outcomes are often delayed. So that makes attributing an outcome measure, like who should be responsible for improving it, a little bit more challenging. So dependence. Children depend on adults both to obtain their care and to evaluate their care. All right? And so proxy report on some measures is reasonable, but it's not so reasonable on others. Give you an example, assessing pain in a child. There's a lot of argument over at what age do you really need to start asking the child rather than asking their parent. Children also depend on a broad range of services, particularly children with special health care needs. They need the medical system. They many times are dependent on community intervention programs, social programs, and school-based services. That range of dependence causes us issues with measurement because of that accountability thing I was talking about earlier. So if I get a poor outcome, who among these different service providers is accountable? Is it all of them? Is it one of them? It's often very hard to know who needs to put the improvement in place or the quality improvement activity in place. And then finally, their differential morbidity. There is low incidence and prevalence of disease in children, which I was mentioning. So it's hard to look at morbidity rates. If I have an adult population, I can look at outcomes like hemoglobin A1C in a diabetic because there's so many adults with type 2 diabetes. If I wanted to look at disease severity, I can look at mortality rates in adults because unfortunately those are high enough that I can use them as an outcome to measure. Neither morbidity or mortality rates are very useful in pediatrics because of the numbers problem. Our numbers are too low to use those as meaningful outcomes. Okay, so I've kind of gone over why outcomes are tough. So then what are the advantages to structure and process measures? Structure and process measures have the ability we can directly change them, right? So as providers of service, either in the medical system or out in the community, we have the ability to change structures and processes of care through quality improvement activities. And the impacts of our QI on outcomes, I know that's what we're trying to influence, it's always going to be indirect and delayed. So it is harder to measure how those structural and process changes affect outcomes. A lot of times we'll put a big intervention into place in hopes of improving care for these kids. And the problem is we won't see the outcome for many years to come. People are impatient. They want to see the outcomes more quickly. And accountability for improving the care and services, it's more clear when we look at structure and process measures. Like I said, outcomes are influenced by multiple medical, community, and social factors, so it's hard to know who should be accountable for improving the performance. a few last additional data challenges. Quality measurement is often driven by the data we have available to us, the data that is the least costly to access. I'm going to give you an example. There are 8 NQF-endorsed care coordination measures for children with medical complexity that our group developed over the past several years, called the Family Experiences with Coordination of Care Quality Measures. They were developed using multi-stakeholder input, including families of children with complex needs. They've been validated, they're reliable, and they're developed for use at the health plan and Medicaid agency level. So you think, great, why aren't we using them? It's because they're survey-based, and that makes them very expensive to implement. So what do I think we can do right now in terms of, I've told you a lot of challenges. I want to talk about some opportunities. I would try to take advantage of ongoing measurement efforts that your organization may already be doing. Consider stratifying pediatric quality measures that you're looking at. Say, for instance, how often do kids go to their needed well child care visits? By a level of medical complexity. There's another algorithm that our group developed called the Pediatric Medical Complexity Algorithm, or PMCA version 3. It's publicly available. It uses ICD-9 and ICD-10 administrative claims, and it allows us to bucket children with pretty high sensitivity into complex chronic disease, non-complex chronic disease, and no chronic disease. And we validated this looking at those 3 categories using medical records-based data, and the algorithm performed, as you can see here, with reasonable sensitivity and specificity for those 3 groups. The other thing is to take advantage of ongoing measurements in your agency. So you may already be implementing the Consumer Assessment of Healthcare Providers and Systems surveys for children. Think about adding any of the 8 NQF FECC, the Family Experiences with Coordination of Care measures to your survey, or some of the items from the National Survey of Children with Special Health Care Needs. Those are also some very sound, good measures for looking at how are we doing with providing services to this population. And there are other ones out there that you could, again, measure by adding them to an ongoing survey effort rather than trying to implement a whole new survey. And then how about there's one newly endorsed NQF measure that I just want to draw your attention to. It was endorsed in June of 2017. It examines continuity of care in the primary care setting for children with medical complexity. So continuity of care is just how often is my child seeing the same 1 or 2 providers every time they go in to see the doctor. And that measure got a huge advantage in that it uses all administrative claims data. And we know from both our work and prior work that children who are more often see the same provider over and over again and who have a higher index, continuity of care index, have decreased ED utilization and increased caregiver reports of receiving all needed care coordination services. It makes sense. If you're seeing the same person pretty consistently, your care is likely to be more coordinated. And then very briefly, because I know we're running short on time, I want to talk about opportunities for improving quality measurement in the future. So we talked about the difficulty with outcome measurement. I think if we invest in infrastructure to routinely collect patient-reported outcomes data at the point of care and in our communities, we're going to be able to expand our ability to measure population health in a more meaningful way because we'll be able to look at outcomes over time. Very important to be monitoring. And we'll expand our ability to then assess if we make these changes in structures and processes of care, how are they influencing these outcomes that we're routinely measuring. We also need to have electronic health records that enable us to do what we call e-specification of quality measures, because then they can be automated and they are not as expensive to collect as manual medical record measurement. And then finally, we need to break down the many data silos that limit our ability to measure what we really think matters for pediatric quality. Things like a child's social complexity, their school readiness, their missed school days, and their graduation rates. There are lots of limits to getting access to this kind of data, and it's really, I think, ultimately going to be very important. And always remember, just because you can measure something, it doesn't mean you should. And just because you want to measure something doesn't mean you can. That's a tenet that I try to live by. And with that, I'm going to stop. Thank you.
Thank you so much, Rita. And a reminder to our participants, please chat your questions for Rita in the chat box. We'll have time at the end to get to your questions. So with that, we just want to now get a sense from everyone in terms of your biggest challenge with Medicaid quality measurement for children with chronic and complex healthcare needs. Please check one, and if you check the other box, please just feel free to chat in the chat box what those challenges are, and we'll take a few minutes. All right, if we could close the poll, please. So a bit of a spread between challenges with resource challenges, lack of system capacity or infrastructure, and then availability of data or measures also. All right, well, thank you so much for completing that poll. So now, without further ado, I'm going to turn this over to our colleagues in New York. You heard from Rita. She gave the overview about data, quality measurement, opportunities, and challenges, and now we're going to hear from our colleagues in New York. We're going to hear from Lana Earl, who's the Deputy Director, Office of Health Insurance Programs with the New York State Department of Health, Sherry Piscatella, who's a Program Director, also with the New York State Department of Health, and then Susan Slade, who's Director of the Bureau of Child Health in the Division of Family Health within the New York State Department of Health. All right, Lana?
Great. Thank you, everyone. Good afternoon, everyone. I just really want to thank NASHB and the Foundation for having us here today to speak to you about what is really important as well as exciting topic. I have a lot of material in the slides for you folks, so I'm going to try to stay within the time and touch kind of on the important stuff with the understanding that you'll have access to these slides about a week after this webinar and can kind of review things in more detail. There's also websites for you to go and look to. Our DOH website is chock full of a variety of information on quality measures in various spots, so I'll try to highlight those for you today. So the first thing for us is I just want to have a few moments to give you the context for which we are looking at the development of quality measures, particularly for children with chronic and complex needs. And I tried to tailor today's presentation with that specific group, obviously, in mind. But it does relate to sort of this slew of efforts that are going on in New York right now that relate to children, and particularly with a focus of those on chronic and complex needs. We are working on a very large transition. We've stood up Health Home for Kids, and we have a transition to managed care going on. We're expanding services, and we're also moving to value-based payments. So that's the key thing to remember as we think about what's the context for how we're developing our quality measures. Another really important thing to share with folks is that New York has done all of its most recent work around quality measures that focus on these initiatives really with a lot of direct input of stakeholders through a variety of avenues. And it's not to say the quality measures and the focus that we're talking about today is the first time that New York has ever looked at quality measures for children. I certainly don't want to leave you with that impression at all either, but just sort of the trend and where we're going is really reflects the context of these large initiatives that we're doing. And as you heard Rita and other folks allude to, the quality measures really for us will grow and evolve over time. And a lot of that is related to some of the things that Rita talked about with respect to, what data is available, what should you be measuring, what is your goal in measuring, et cetera. So we in New York are very cognizant of those things as well. And so we've kind of categorized through some of our work some of how we think about measures. What's readily available, valid and feasible, it's category 1. What might be present some concerns regarding feasibility, or maybe there's some data issues, but we think that we can confidently operationalize it, category 2. And then category 3, not currently feasible, but very important to keep those into the parking lot list, right? Because especially as we think of things, what do we want to involve to over time? and maybe quality measures that touch upon, for example, social determinants of health, which is really a very prominent topic that we're also discussing in New York, could be an example of that. And we also want to think about how do we evolve to outcome versus process measures. And as Rita talked about, that's not at the expense of dispensing of all process measures, but what is the appropriate balance and where do we want to get to for the environment that New York is evolving to, particularly with value-based payments in the wing. The initial development for our the quality measures with children with complex needs really has focused heavily on our health home and our move to value-based payments. So the next slide really just shows you the kind of key things that are going on in New York that are pertinent to quality measures development for children with chronic and complex needs. So the Health Home Serving Children model, which I'll very briefly talk about, this whole children's behavioral health and health transformation that's going on for Medicaid, value-based payments and how that affects children, and then just children with special health care needs program in New York, which Sue will talk about a little bit. And all of these things are happening together, and we're trying to make sure as a state that we kind of integrate those efforts, even though things are happening on different timelines. And you'll see that those different timelines has impacted how we've been developing and thinking about quality measures. So on the next page, just a little bit about a couple of those bubbles we just showed you. So the Children's Medicaid System Transformation. I mean, the key thing from this slide is all of the work here really focuses on children with chronic and complex conditions. So those with behavioral health, so SED and SUD, complex trauma, particularly in New York, very exciting topic for us related to health home, which I'll talk about, medically complex and fragile children, and then also children in foster care who also tend to have very high needs, as demonstrated by a lot of really good data around foster care. So what are the goals? Very obvious goals, I think, that you've already heard folks allude to earlier on in the opening of the presentation, but keeping children on their developmental trajectory, keeping children at home, identifying needs early, really has been a primary goal of how we think about the development of the transformation, but then also a key part of the goal is maintaining accountability for improved outcomes and delivery of quality of care. So, I think lots of folks who've been around in state government for a long time work on a lot of things around system transformation. I think in New York, we've been really cognizant about integrating the quality evaluation of that work. And this is a way to do that about delivering quality. How are we measuring if we're delivering quality outcomes in the transformation? Next slide. So just really quickly, how are we trying to achieve the goals? So we want to increase appropriate interventions by enhancing the service array. We want to expand services and eligibility for those services, so putting more tools in the toolbox. Offering children in Medicaid Medicaid services within the managed care delivery system, right? We want to make sure that and leverage that tool to integrate the delivery of both physical and behavioral health services. And we want to integrate approaches to care planning and service provision, in particular with leveraging the health home model. And we are shifting managed care in the children's transformation to facilitate one of the key goals of shifting our focus from volume to value through value-based payment. New York is under a continual move right now to move to value-based payments by the year 2020. So that's also part of the horizon for which we think about developing quality measures. So the next slide, just to give you some of those key timelines that are sort of driving our development of quality. So the first thing was December 2016. We implemented the health home model for children. We're very excited about that. We are now a year old, which is hard to believe, but here we are. And then in July 2018, here are some of the key components of that children's transformation. And I'm not going to read them to you all, but again, it's about making HCBS services available under a managed care environment, making them available to a larger array of children who are meet level of care, institutional level of quality, but also level of need, and just providing new state plan services to help prevent escalation to HCBS. So all of these things are going on. And then in January 2019, we'll also have the voluntary foster care agency children move to managed care. And so why is all of that important? It's important because I think these things, as they happen and evolve, need to be kept in mind as we think about our further development of quality measures, even beyond what I'm going to talk to you about today, because I think we want to keep in mind how are we evaluating how these things are impacting the quality outcomes for children with chronic and complex conditions, since this work basically focuses on that population. Next slide. So again, I just indicated that health homes are a year old, and we're very excited about that. Health homes was really the first component of the Children's Medicaid System transformation, where we really wanted to ensure that we were providing comprehensive, integrated, person-centered, children, youth, family-driven care management for children with complex and chronic conditions. And by definition, for eligibility for health homes serving children, that is that group of children. One of the things we're really excited about is we worked very closely with our partners, SAMHSA and CMS, to expand the criteria for the health home model to include complex trauma as a single qualifying condition. I believe we were the first in the nation to do that. We're very excited about that. For anyone who's interested in that, there's lots of information about how complex trauma is defined, and a lot of work New York did to help folks go through assessment tools and other things to determine if someone has complex trauma as defined for health home and can be eligible for health home. The other thing that we are doing, which I think is really exciting, is that there is a system of care grant for a regional pilot that is helping us think about how we can potentially integrate high-fidelity RAP care management model into health home. So this one is a little interesting because it's thinking about how can an approach to care management within a health home model that is already very directed to children with complex and chronic needs be tailored for a specific type of health home, care management model, the high-fidelity RAP model. And so that work is going on as well. So on the next slide, within the health home model, what was our process for identifying quality measures? We really came ahead of a lot of the VBP work. We worked, or value-based payment work in New York. We worked very closely with stakeholder input as part of tailoring the health home model for children. We have the New York State Plan Amendment and the CMS Health Home Core Quality Measures as part of our initiatives. You can see the range of state agencies that we work with, and we landed in a place where we have 33 clinical measures, 5 process measures, and we were developed in advance of BVP, but you can see that we have some Category 1 and Category 2 measures in our list. So in the next couple of slides, you can advance, please, really just list the clinical measures that are in our data set. We have clinical measures that relate to children only. We also have clinical measures that relate to children and adults. In New York State, the health home model was originally launched in 2012 and served adults only. So we had quality measures up that applied to adults. And so the ones that certainly could apply to children, we did that, and then we developed new ones that apply to just children only. So, as indicated before, I would say this is sort of, the list is originally sort of the low-hanging fruit, ones that are developed by NCQA and that are readily available in data collected for us. We also have a list of utilization and process measures that we are looking at. A lot of those process measures really focus around things like ED utilization, primary care utilization, those types of measures that folks typically look to. We also have process measures which have really focused around just the level of enrollment, wanting to make sure that our enrollment numbers are as high as possible for both adults who meet the health home eligibility requirements, but also for kids, and in light of the fact that we just stood up the health home program, one of the things we're focusing on is just plain old marketing of it, getting children and families engaged and enrolled. And not on your screen, but we also have other process measures that get collected on a quarterly basis in New York. And with those process measures, look at are things like how was care management delivered? What is the volume and type of interventions, for example, the number of assessments, the number of plans of care? That type of information is also collected. Next slide, please. So again, by the year 2020, all managed care organizations must employ VBP systems that reward value over volume, so for at least 80 to 9% of their provider payments. New York is currently at 38.23% of Medicaid payments. So with respect to children and value-based payments, in the fall of 2016, the state established a Children's Health Value-Based Payment Subcommittee and Clinical Advisory Group, which really brings together a uniquely child-focused perspective to payment reform. I just quickly want to let you folks know that the group in the value-based payment world really has been a thoughtful group, and even before they began to develop quality measures, they sat down together and developed a list of principles. And I'm not going to go through all of those today, but they are in the appendix. But one thing quickly that I would like to just read for you is the principle that they, the value statement that they developed from the guiding principles to as they began their endeavor of thinking about quality measures in a value-based payment setting. And that value statement is, focusing on the healthy growth and development of children will improve their quality of life. Children require a value-based payment approach that acknowledges the specific needs attended to each developmental stage and the unique opportunity to improve health and life trajectories, as well as the near-term improvements that are possible from direct health interventions. Support and recognition of families and caregivers are central to improving children's lives. And I think throughout the principles, you'll see that one of the things is families need to be involved, and that children are not little adults, and we also need to recognize that those measures need to grow over time as they grow, and Rita talked a little bit about that as well. And then just really quickly, I want to talk a little bit about some data observations. There are about 2 million children enrolled in Medicaid. Generally, children are a low-cost population compared to adults, and there's some data that we have on the screen for you. But I think the real takeaway here is that while the average expenditure for about 90% of the population is relatively low, the remaining 10% of our Medicaid children enrollees account for a full 50% of total Medicaid expenditures for children in 2014, leading us to the conclusion that those folks those are folks with complex and chronic needs, really require a separate and important focus around how we think about developing quality measures. And the other issue here is, even as a group in the top 10%, they really require some stratifications amongst themselves and are not homogeneous. They're rather heterogeneous, and they have behavioral health needs, developmental disabilities, complex chronic conditions. We have medically fragile children in there. We also have children involved in child welfare. Next slide. So the Value-Based Payment Subcommittee for Children really had several tasks available to them. I'm really going to focus on two of the tasks that they worked on really quickly. And their final report was released in September of 2017. I would encourage folks to read it. There's some really good and key information there. The next slide really is just a quick focus on the committee's work towards developing options for addressing the unique needs of children and families with chronic and complex conditions. So the key takeaway here is that the group decided that they really need more deliberation and more work. That was primarily driven by time and data constraints. Again, the heterogeneity of the subpopulations that we think of as complex children. And then the recognition that some of these children are not yet in managed care, and that comes back to the Children's Medicaid System transformation and the timing of events in New York around a lot of the Medicaid reforms for children that we're doing. So, and then the next slide, they recommended several next steps for value-based payment for children with complex needs. And you can read them here at your leisure, but the key is that We need to get a definition for VBP purposes and the issue of feasibility of VBP models for small and unique population of data sets. And this gets to the number issue, the size of the group that Rita also talked about, whether a payment model for families and behavioral health complex needs is viable and feasible, what measures current VBP arrangements are and how we should take into account them, and whether centers for excellence for very small subsets of children are a viable option for thinking about VBP. And since we're running short on time, I think what I'd like to do is just go to slide 50 if we could. And so while the group set aside working through what they could do at the moment for quality measures for children with complex needs, they went ahead and developed a universal child measure set that really can be applicable to most of the VBP arrangements that exist today. And so here's a set of quality measures that folks can look at. And there's 20 of them. We let you know which is a Category 1, which is a Category 2, and we've also highlighted for you others that were already in existing value-based payment arrangements that were developed just for the general population. So that is some good reading material for you at your leisure. And so let's see. Why don't we go ahead and jump to slide 53. You can just see our next steps here, but we want to implement the CAG recommendations. We want to further integrate quality measures developed in VBP arrangements into health home measures, identify quality measures related to complex trauma, and develop cross-system measures for children. So these are really some of the longer-term visions that we want to thinking about quality measures as we develop them. And with that, I'm going to turn it over to Sue Slade.
Thanks, Lana. So I've been asked to speak a little bit about the Title V role in Medicaid redesign efforts, and you might be wondering what the role of public health is in Medicaid redesign efforts. Well, for my public health partners that I see answered the poll question, I know there's several of you on the phone, you know that Title V historically, the role has been to assess the entire system of care for children with special health care needs and their families, both public and private. And we in New York State do that in several ways. We have a local children with special health care needs program, and we also look at our national children with special health care needs data. And we also talk to families directly. So those are three different methods that we use, and I want to just briefly discuss what each one of those methods refer to. In New York State, we provide grants to local health departments to provide information and referral services to families of children with special health care needs, regardless of their insurance type. And through this public health work, we identified the strengths and gaps in services and supports for families of children with special health care needs to better inform state planning processes. So when the family taps into the public health system, we try to find out what brings them there. Are they insured but they don't know how to navigate the system of care to find what they need for their child? Or is it because their insurance lacks coverage of a certain benefit? And we try to link them to what the families need. We also try to further understand the subset of children with special health care needs from the state sample of the National Survey of Children with Special Health Care Needs, and we'll plan to analyze the 2016 children's sample of the National Survey of Children's Health. And we also have embarked upon a systems mapping initiative where in public health, we are going out and speaking with families of children with special health care needs throughout the state to hear about their roles, their responsibilities, their needs and wishes regarding the services and supports they need for children with special health care needs. Next slide, please. And in our review of the National Survey data, specifically for New York State, we learned that 1 in 4 families report that their child's needs consistently or greatly affected their child's activity of daily living, and that 1 in 7 of the New York State families surveyed, their child missed 11 or more days of school during the past year due to illness. And this is a significant amount of time, almost 2 weeks of school that they missed during that past year. And we know that the impact of having a child with special health care needs is very great on the family. 1 in 4 families reported that they either had to reduce or stop working due to their child's special health care needs. And this loss of income significantly affects the entire family. A significant portion of families reported financial problems due to their child's special needs, and 20% reported that they paid more than $1,000 out of pocket. And 1 in 8 families reported that they spent 11 hours or more each week coordinating their child's care, such as making doctor's appointments, arranging for medications or supplies, or talking with providers. And so that the family themselves are coordinating care for their child amounts to more than 1 full work day, if you were thinking of this in work hours per week. And also the national survey data is very consistent, next slide please, with the preliminary data that families themselves have reported to the state Title V program. The families, next slide please. The families reported that once they receive a diagnosis, they really need help finding appropriate resources for their child. They would appreciate getting this help rather than trying to find the resources on their own. And once resources are identified, they need referrals to resources and programs as well. They could use assistance with this. And the families are telling us they're spending a significant amount of time communicating amongst providers for their child, and they wish that their providers could facilitate communication amongst themselves. Families are also requesting social outlets for their children with special health care needs and places where they can go to interact with other families and children who have special health care needs. And as we learned that a significant percentage of children miss time from schools, families also report that they need support from advocates that are knowledgeable about school systems and programs to help them. And we think that all this wraps up to the fact that Health Homes for Children can really help with care management for children with special health care needs, and that we in Title V will continue to work with Medicaid to link families to Health Homes for Children. I wanted to wrap it up there so that we have time for questions. And I'm going to turn it back to the moderators.
Yep. Thanks, Sue, and thanks, Rita and Lana, for really great presentation and very substantive. And again, for our participants, just want to remind everyone that we will send out the slides within about a week and the recording as well. So we have time for about a couple questions, and I think what I'd like to do is just to kind of ask both of Rita and of Lana and Sue, you know, given what you've laid out for folks in terms of some of the challenges with regard to quality measurement for kids with special health care needs, what would you kind of be your top recommendations for states or others interested in really kind of trying to embark on this work or trying to strengthen it? And within that, and Rita, kind of some of the questions that came up were around the challenges with the heterogeneity of the population, which both of you talked about. So could you just both kind of comment on kind of your lessons learned, your one big recommendation for participants, and then maybe within that address some of this issue that both of you have talked about the heterogeneity of the population?
Sure. This is Rita, and the one thing in our work over the past 5 to 7 years with this population that has really hit home for me is, although there is a lot of heterogeneity, when you talk to the families of these children, and we did a lot of multi-stakeholder engagement as we tried to develop quality measures for them, what you find is, although their conditions are heterogeneous, the needs that they have are not. In terms of just what was on that last slide that Sue was going over about, needing help getting services, having somebody who's knowledgeable about, school issues and school services that are needed. It doesn't matter if you have a child with a developmental delay, a mental health problem, medical fragility. Those issues come up across the board for families. And so I think we need to stop getting so hung up in our adult framework of thinking like, oh my gosh, if we don't have like 1,000 people with condition X, we can't do quality measurement. I think what we really need to do is look at this population, and there are strata within the population, right? And that's why we talked about, I talked about PMCA and looking at kids with complex chronic disease, kids with non-complex chronic disease. And then I think an important and often left out group are kids with social complexity. So those are the main strata I would look at, and I would not get so hung up on what are the variety of conditions that fall into those strata. And then I would think very hard about, from just a feasibility and, in measurement standpoint, really looking at measures that are NCQA developed or NQF endorsed, because they're going to meet all those criteria I was talking about: reliability, validity. They've been shown to impact outcomes, even though they're process and structure measures. And then looking at those by these different larger buckets of children, so children with medical complexity or non-complex chronic disease or social complexity. So that would be kind of my main suggestion to the group.
Thanks, Rita. And Lana, kind of in a couple sentences, New York has taken on a lot and has clearly been doing this for a while, and you have other things you're working on, but what would be kind of your big takeaway for other states interested in this work?
So agree with everything that Rita said. I think the other real key thing that I think we have found to be extremely helpful is really just involving stakeholders and providing formal forums to do that, because they are the ones who are out there serving these children. They have a lot of boots on the ground experience and bring a lot to the table, and they're really very valuable. And the family framework for developing quality measures is super important. And this kind of crawl, walk, run approach. So as Rita said, using the NCQA standards that are available to you, and then thinking about how can you, morph your way and keeping a line of sight on development of new measures that do look at the social circumstances, social determinants of health, all the schools, the system of care. So kind of thinking about it in sort of a longer-term trajectory as you kind of begin your initial development and list, and just think of it as an evolving product.
Okay. Well,
Karen, there's one other piece that I see keeps coming up on chat that I'd just like to make a brief comment on, and that is, how do we deal with states that are so focused on adults because they're so much higher cost than children in general? I think it's important to remind the policymakers and the people in those states that if you don't take care of the kids when they're younger, say take a non-complex chronic condition like obesity, if you don't address the quality of care for that child early on in their life, or a kid with social complexity, you're going to have all kinds of adult disease down the line. So really reminding them about the life course, and that things that we neglect in childhood and adolescence are going to come back to haunt us in the adult population.
Thank you, and thanks, Rita. And so I want to take this time, we're at the end of our hour, and to thank our presenters. Thanks to Rita, Lana, Sherry, and Susan for a really rich presentation. Again, remind everyone the slides will be available and sent to you along with the recording. There's a slide showing right now with a list of selected resources. There's many more, including the issue brief, which is the second bullet listed, that's going to be released tomorrow through the NASHB newsletter. That's at www.nashb.org. So again, thank you all. I want to thank Lucille Packard Foundation for Children's Health for their support of this work, and have a great rest of your day.